Hello, everyone. Welcome to our webinar today. We are so glad to have you join us for this discussion. Before we dig into the content, I do want to share that we will be sharing this recording and the slides from today's presentation with all registrants. Now, let me introduce you to our fantastic panelists for the day. Amy Visano is a nationally recognized health policy leader with deep experience in Medicare and value-based payment. She serves as Managing Director of Medicare Services at HMA, drawing on more than 2 decades of experience shaping federal payment policy, including senior leadership roles at CMS and the Center for Medicare and Medicaid Innovation. Ryan Howells is a digital health policy and interoperability expert based in Leavitt Partners' Washington, D.C. office, working closely with the White House, Congress, HHS, CMS, and Veteran Health Administration. Since 2016, he has co-led the Karen Alliance, advancing consumer-directed FHIR APIs that are now implemented nationwide and recognized in federal policy and practice. And Kate Delisle is a principal in the strategy and transformation practice and leading expert on alternative payment models. She oversees the firm's value-based payment market research, advises clients on payment and delivery transformation strategies, and supports national collaboratives to advance high-value care. At this point, I'd like to turn it over to Kate to get us started.
Awesome. Thank you, Tiffany. We're really excited to have you joining us today and to have experts Amy and Ryan on talking about a really exciting and novel approach to paying for tech-enabled care, the new access model. There's been a lot of buzz about it. We'll talk about it today. We'll start by zooming out to understand how the recent announcements over the last few weeks and months, and also the last year or so since the new administration entered office, putting in context the access model and what it means for the industry as CMS looks to modernize the tech infrastructure that will really serve as the foundation for the model. So we'll look at what is CMMI doing. We'll talk about access. What do we know about its current design and what potential applicants should be considering. We'll also give a brief nod to LEAD, another really important model that we're still awaiting a lot of details on, but was also announced around the same time. And then Ryan's going to give us, school us on the CMS Health Tech Ecosystem and how that broader foundation is really going to support and enable this new model access. Time permitting, we'll conclude with how we can support your organizations in evaluating these opportunities. First, we want to just ground ourselves in the CMMI strategy that they released spring of last year. Every new administration, as they come in and take over at the Innovation Center, they put forth their new priorities for models that they'll tweak and announce over the coming years. And we've been hearing from this administration and CMMI led by Abe Sutton an interest in advancing new models and adjusting existing ones along these 3 pillars, really looking to promote evidence-based prevention, particularly focused on chronic illness and in the onset and escalation of chronic disease through leveraging technology, new approaches to incentives, and access certainly is a reflection of how they plan to do this. The second pillar, empowering people to achieve their health goals, again, by better leveraging consumer-focused technology and both provider and patient-directed incentives. Access also clearly is aligned with this pillar. And then the third, driving choice and competition, looking for ways to use CMMI's authority and models to really promote competition based on performance, and certainly access also checks this box. And so it's been exciting to, over the last year or so, been hearing more about these priorities. Now in recent weeks and months, we've been seeing how they're planning to bring these to bear through a series of new model announcements. Amy, do you want to talk to us about the models that have been announced recently since this new administration's taken office?
Sure. I'm not going to go through all of these in detail. We've had some webinars where we've talked about some of them, and there's a lot of other material out there. But just to put it all in context, as Kate was saying, there is a mix of voluntary and specialty models, voluntary and mandatory models, primary care, specialty, other types of services, starting with the ambulatory surgery model, a model for specialists, mandatory model for specialists treating back pain and heart failure in certain geographic areas, the AHEAD model, which has been in place, but now with an expansion or additional opportunities for geographic participation there. TEAM, another episodic-based mandatory model that went into effect just earlier this month, as did the WISER model, which is a prior authorization model, but also a model for tech vendors in certain states to be doing this prior authorization. And I think some of the things that are happening in that model, Ryan will touch on later, using about the technology and infrastructure that CMS is looking to build out. And if we go the next set of models, the ones that really came out at the end of the year, Access, which we'll be talking a lot about, and Lead, which we'll also mention, so I'm not going to really talk about them here, but MAHA Elevate, which is testing lifestyle-based interventions, different type of model, not necessarily a provider payment model, but $100 million in funding for 30 evidence-based proposals. The applications for that, it's not a request for application, it'll be a notice of funding opportunity to be coming early in this year. And then the three drug-based models, Guard, Globe, and Balance, that all sort of came out at the very end of the year, looking to address drug cost issues, Guard for Part D drugs, and addressing rebates to manufacturers when they exceed international benchmarks, otherwise known as most favored nation pricing. Similarly for Globe, with a focus on Part B, and then Balance was a model addressing the prices for GLP-1 products. And so there's a whole variety of different models here, many of which folks on the call here may be interested in participating in or have maybe impacting them. And we're always happy to talk more offline about those different things. And I think we have some of our colleagues having some webinars coming up on the drug space as well. So we continue to look at these things and how they all fit together and serve the different provider, beneficiary, other populations as well. So yes, Innovation Center has been very busy. I think there's more to come. I think a theme on many of these models is that there is not the full details yet, but more to come. So I think as CMS colors in the lines in the coming months, it will help us all collectively understand better how they all fit together and what those impacts will be.
Amy, before I move on to talk about Access and then Lead, we got 6 models in December. As you said, they were very busy. Like, do you anticipate new model announcements, or should we expect this is the batch of models that we should be looking at in the short term?
I think there's always more to come. There's lots of different areas that they could still be doing more work in, whether it be in specialty services, more primary care, more, what's going to happen with AHEAD and state-based models. Certainly they've indicated an interest in the Medicare Advantage space. So there's a lot of other potential things that they could be doing to fill out their portfolio. But I would say that, there has been criticisms of the Innovation Center in the past of having too many models, being too scattered, and not focusing on the core issues of really trying to achieve that financial savings. And so I think they've tried to address many of those issues in the design of these particular models, especially the use of mandatory models. But it is a lot to be balancing and a lot to be running for a relatively lean team over there at the Innovation Center.
So keep an eye out.
Yeah.
Awesome. So now that we've kind of set the table with CMMI's priorities, the announcements they've made on new models and some changes to existing ones in recent months, especially with the big splash in December, should we turn to talk about Access? Amy, do you want to walk us through it at a high level?
Sure. Something I should have said about all of those other models, that they should win an award for best acronyms or most creativity in the acronym space. So we call it Access. It actually stands for something: advancing chronic care with effective, scalable solutions. There's a couple of particularly notable parts of this model. One, it is a 10-year model, which is sort of the trend for CMMI models, but 10 years is a very long time to run a model and to test it and imagine, where we were 10 years ago in sort of technology and clinical care. So expect that this model would be evolving over time, but also the focus on technology-enabled care, something that has not been done previously. Other payers have struggled with how to pay for these services. So CMS here is really thinking outside the box and how to deliver these services. Definitely, what the Innovation Center was created for. So the idea that, they're using their authority to sort of test these alternative approaches is very much in line sort of with their vision and their mission. Ultimately, though, the participants must be a Medicare Part B enrolled provider or supplier. So it needs to have that connection to the Medicare program. It's fee for service beneficiaries only, so doesn't include anyone or plans in the Medicare Advantage space. As of now, they have these 4 clinical tracks, the early cardio kidney metabolic conditions, the cardio kidney metabolic conditions, musculoskeletal conditions, and behavioral health conditions. And we'll talk more about all of those momentarily. And then there's sort of 2 parts of the payment aspects. Again, we don't have all the details on this, but there's going to be outcome aligned payments, meaning that the participants are only going to get paid if they meet those specific outcomes, which is very different than fee for service. And so we'll talk also in a moment about those specific outcomes and how CMS is going to be measuring them. And then co-management payments for referring clinicians. So the patients who are seeing their doctor, if the doctor says, I think you would be a great candidate to participate in the access model, and they have a partnership then with the access participants, the physicians can get paid for that management of it. And applications are currently open on a rolling basis. The model begins later this year in July. So a lot of things, and we're going to dig into further here. I want to mention briefly the FDA Tempo pilot. This is something that is complementary to Access and shows all the parts of HHS working together, and CMS has, there's been criticisms over the years of FDA and CMS not coordinating. This is a great example here of how they're working together and thinking about removing those barriers that could potentially be in place to prevent somebody from coming in and participating in Access. And so the Tempo pilot is for digital health device manufacturers that don't have an FDA authorization yet, but they can apply to Tempo. And so FDA is going to select about 10 manufacturers per clinical condition where they will waive enforcement discretion, allowing the devices to be covered under the concept of in the access model. FDA, like I said, is getting statements from the manufacturers who are interested in this. The manufacturers need to demonstrate that they are safe, what their quality controls are, and then there will be a collection of real world evidence to support this through the experience in the model. The FDA has been very clear. There's no guarantee you get FDA approval, but it allows more flexibility in CMS to look at a broader potential universe of model participants. If they haven't gotten through the FDA process, this gives them some flexibility to be able to do that. And so I think there's some really interesting outcomes from that experiment with FDA, and we'll see if FDA, what they think about it and if they could potentially expand this or make this a more permanent approach to give flexibility, especially in the context of an innovation center model.
Amy, before we move on, just quickly on Tempo. So as you said, they're currently accepting letters of interest or intent from potential applicants. And CMS, I believe, has said in March they'll come back to some of those applicants with some clarifying questions. Do we yet have any understanding of the deadline for the Tempo applications?
No, I think they are expecting that sort of be on an ongoing basis. And I think they said they're going to select up to 10 manufacturers for each clinical track. I can imagine that being sort of an ongoing conversation, given the 10-year model, given the rolling applications for access, they can work together to ensure that there's, if you don't have your moment right now, if you're not ready right now, it seems like FDA is leaving it open that they could, you could come in later, but they did not say really when that is. And I think probably they're going to want this going, sooner than later,
Sure.
just to be able to do that. But as with any innovation center model, they can modify as they go along, and presumably FDA could also modify as they gain more experience in this as well.
Sure. Okay. Thank you for that. All right. So this is the high level view of access. Now let's double click into some of these areas. First, with the 4 initial clinical tracks that Amy described on the last slide, you can see here what we know about the qualifying conditions that a beneficiary must meet to be eligible for a track. And also the participants that opt in to be a participant within each track must be responsible for managing all of the qualifying conditions a given beneficiary has within a track they're enrolled. So you can see in bold here the qualifying conditions along each of those 4. And then also on the right-hand side of this table, the outcomes aligned payment, those OAP measures that they will use. We'll talk a little bit more later on about what we know around payment and how performance within these measures will impact payment. We're still waiting on some of those details. But really the tracks themselves, these clinical focus areas, were chosen for a few reasons. The prevalence of these chronic conditions among the Medicare population, the clinical homogeneity within each of these tracks. It can be generally managed in similar ways with similar resources, and also just very clear evidence-based established clinical pathways for what is best practice for how to manage these clinical conditions. And there are several tech-enabled care companies or tech-focused care companies that have been and are actively managing the conditions listed here, and a pretty robust evidence base for how technology-supported care can help in combination with traditional Medicare providers, or traditional providers rather, in connection with primary care teams, can really be effective in augmenting and managing a care experience using technology. And the requirements of access are pretty flexible in the types of tech-enabled care, how they define that, whether it's lifestyle-based apps and trackers or wearables and telehealth. CMS expects access participants to use a combination of care interventions and tech solutions to help manage these conditions, so long as you feel confident that you can achieve these measures on the right here. So let's talk just briefly about what these tracks will mean for a few different stakeholder groups. First, for the participants. So these are the Part B enrolled providers or suppliers defined by a single TIN. That's the participant as it's defined in this model. As I said, they'll be responsible for managing all of the conditions that a beneficiary has within a given track. Participants can also participate in multiple tracks. So if they have solutions that manage both, early cardio, kidney, metabolic, or CKM conditions, as well as depression or anxiety, they could participate in both of those tracks. And a beneficiary that has multiple conditions represented in multiple tracks could also participate in multiple tracks, either with the same participant or with different participants. So there's allowance of that kind of overlap. The participants will receive a fixed payment for managing beneficiaries, all of their qualifying conditions over a 12-month period. We'll talk a little bit later on about what payment will look like. But importantly, this is the really novel piece of the access model, is that full payment is contingent upon achieving those track-specific clinical targets. And those will be relative to a beneficiary's baseline that will be submitted upon enrollment, and whether or not the focus really is on improving relative to that baseline or achieving control, like meeting that guideline-directed target. And I believe I saw a question in the chat, do we have all the details yet on the measure specs? The answer is no, but CMS said they will release that ahead of the application deadline that's coming up in April. So I've touched on some of these already related to beneficiaries, that they have to have qualifying conditions within one or more of these tracks. They also cannot have any excluded conditions that CMS has specified at the end of the RFA, and some examples of what those clinical exclusions, more severe cardio, kidney, metabolic conditions like active, unstable angina or severe heart failure, if they have moderate to severe dementia or other cognitive impairments, patients that are over 81 by the end of the measurement period and have an indication of frailty. So just to give you some examples, these are for relatively healthy but chronically ill Medicare beneficiaries that aren't anticipated to have higher level care needs that might lead to duplicative services or redundancies or further fragmentation in how that care is managed for beneficiaries who are particularly ill. And so you should look at that list of excluded clinical conditions. As a beneficiary, you can align with one access participant in a given track, but you could also participate in multiple tracks with the same or more access participants. One exclusion is with ECKM. If you are aligned in an ECKM track and graduate to having CKM conditions, you can move into that track without waiting for that 90-day minimum. There's a 3-month lock-in period after which you could switch or disenroll from access. And so the RFA spells out in a little bit more detail what that track switching might look like. And then lastly, how is CMS thinking about these tracks? They have said that they may consider adding additional tracks in future years. These are very well established, not only in clinical pathways, but in the use cases for tech-enabled care, hence why we started here. They've also said they may periodically update and add or remove measures as they learn more. And then the last bullet here, this is a really cool and novel part of this model, is that they plan to publish participants' risk-adjusted outcomes to help promote performance-based competition. So there will be a directory where all access participants are listed. It will be open to the public, and it will say which track they're participating in, if they are going to waive beneficiary Part B cost sharing, and ultimately their outcomes, risk-adjusted outcomes aggregated across a population. This data may not be available until the first 12 or 18 months into the model timeline as they gather that data over the first performance period, but a really exciting opportunity to allow beneficiaries and providers also to opt in or refer according to really who has the best clinical outcomes, which is an exciting development of this model. Ryan, let's turn to you and talk about some of the really interesting foundational tech infrastructure that will help to facilitate both the enrollment process and ongoing management of a model like this.
Yeah, one of the things this does, Kate, is this has an opportunity to really advance the ability to modernize our healthcare data ecosystem. One of the things that has been clear throughout the model is that they want data exchange to be using these what's called FHIR APIs, Fast Healthcare Interoperability Resources Application Programming Interfaces. We love acronyms in healthcare, so those are our FHIR APIs. And the goal of this program is to figure out ways where that information could be shared with CMS in a manner that is consistent with these APIs. So they talk about this idea that we need to have consent to participate. There's an opportunity here to potentially do that with the CMS aligned networks where digital identity is actually going to be a thing, which we'll talk about here shortly. They talk about verifying the coverage, which with a CMS access eligibility API that's still yet undefined, but there is an opportunity to use, similar to what's being used in the CMS Aligned network, to what's called the Care and IG for digital insurance cards, something that Leavitt Partners actually created a few years ago. And there's about 5 million of these digital insurance cards in production today. So they could potentially use that as an open standard for how the eligibility API works. They also talk about validating the clinical eligibility and specifically the option to provide claims data for care coordination purposes. The BCDA API, if you're not familiar with that, is what's called the Care and IG for Blue Button. And that's really the claims data model from all payers in the country. And so, again, something that we had developed previously and is in production actually today. But the point of this is that I think folks need to understand is that CMS is all in, not only on technology-enabled services for beneficiaries, but also the idea of moving towards more of an API-based infrastructure that actually supports beneficiaries and helps to be able to modernize our entire data ecosystem.
Thanks, Ryan. So you can see in the process here, beyond just the technology components of when access participants need to obtain beneficiary consent, do you want to be in the model describing access, and then also there are requirements for how access participants need to share data with the broader beneficiaries care team. This model is an exciting opportunity for tech-enabled care companies, but also is giving some traditional providers some heartburn around how they will coordinate. And CMS has tried to make very clear and streamlined what that process will look like. But I think we will see when the model becomes implemented. One important factor before we move on is that unlike ACO models or many other CMMI models, beneficiaries are not aligned based on claims history or which providers they're seeing. Beneficiary alignment or enrollment with an access participant is fully voluntary and done prospectively. So beneficiary shopping for which access participant they want to manage their care, and also provider referral using that public-facing directory will help to facilitate that according to who's producing the best outcomes. But really, it's beneficiaries getting to decide and can switch access participants every 90 days should they be unhappy with their current access partner. Awesome. Let's talk about what we know. And there's still a lot of unanswered questions. We did receive the RFA that gives us more clarity than was included in the initial December announcement. But as we know, with all CMMI models, really the devil's in the details. We've seen a lot of interest and slides with many logos of potential organizations that may be interested in participating. And we have a hunch that when these final payment details are announced, that may really kind of narrow the field. But let's talk about what we know and how payment is going to work within Access. So the real novel approach to payment in Access is it's fundamentally untethered from fee-for-service or historical expenditures. It's not associated with activity-based reimbursement of any kind. It's really about paying these tech-enabled care companies or participants based on their ability to achieve specific outcomes targets. And CMS has said they've taken inspiration from emerging performance-based pricing models in the commercial market with private payers or employers, and also just looking at the tea leaves of where broader trends in AI-enabled services are heading. And when you can confidently manage patients using technology and have decreased margins, that really increases the operational viability of going at risk. Now, risk looks a little different under Access. We'll talk about what that looks like. So OAP amounts, which we do not know the rates yet. I know this is probably the number one question of our attendees today. We don't know these amounts, but they will vary by clinical track. They'll also vary by performance period. So for the first 12-month performance period, and that starts when a beneficiary is enrolled, it's not aligned with the calendar year, but follows the beneficiary. The first 12 months, that initial period, there will be higher payment for the costs associated with enrollment and ramp up and really getting patient integrated into care pathways. And then in subsequent performance periods, there will be a lower payment, and CMS is calling this a follow-on period. They don't require access participants to offer a follow-on period, but they expect that they will. Payment will also be adjusted down for when an access participant is managing a beneficiary's clinical needs across multiple tracks. So there will be an adjustment to account for that expected efficiency. So that's defined at the track level. CMS will pay half of that amount upfront via these quarterly payments to participants. The remaining half of that OAP amount is going to be withheld, and this is contingent upon their achievement of specific outcomes, or I should say reconciled based on their actual performance. And that remaining 50% that's withheld will be subject to two downward adjustments. There's a clinical outcomes adjustment and a substitute spend adjustment. The first, this clinical outcomes adjustment, or this outcomes attainment rate, OAR, not introducing a new acronym here, but this is associated with your ability to demonstrate improvement or achievement along those clinical measures that we looked at associated with each of those 4 tracks. So it's the percentage of your aligned beneficiaries that completed the full 12-month period. So how well did you engage them and keep them retained throughout the 12-month period, and that met the required OAP measured targets. And in the first year, this threshold is just 50%. Did half of your aligned beneficiaries complete the full measurement period, and did they hit those targets? If you get at least 50%, then you'll get the full amount paid back that was withheld from that 50%. The substitute spend rate, this is the percent of the aligned beneficiaries who did not receive substitute services from other Medicare providers or suppliers for the same condition during the care period. The idea here is to say, if these OAPs, these payments are in lieu of Medicare fee-for-service, CMS wants to ensure that there's not double dipping or duplicative services for the types of care that access participants should be providing. And so they'll look to say, in the list of those substitute services, it's included in the RFA, at least an initial list. So did at least 90% of your aligned beneficiaries not receive any of those substitute services to ensure that there's not duplicative spending? And so you can use new access to claims data from CMS to help try to manage this and mitigate this. But it's really about preventing your aligned beneficiaries from receiving duplicative services from other providers. So a care coordination and visibility challenge for access participants. On the right, you see some unanswered questions, the biggest one being the exact OAP amounts. We also don't know the specifics of the outcome target methodology or the benchmarks against which participants will be measured, or beneficiaries rather will be measured. We don't understand yet the full implications of beneficiary switching upon reconciliation. They're allowed to move every 90 days. There will also be a rural add-on payment for patients in the early cardio-kidney and the cardio-kidney metabolic tracts, and that's associated with the costs of cuffs and other devices that may be more difficult to obtain in rural settings, is what CMS has said, but we don't have the full figures there. Amy, I know that we're getting a lot of questions and people are asking about payment. Could you speculate as to when we might receive more detail, if the applications are due in April? Any other commentary you'd add about the big unknowns here?
Yeah, I mean, I think this is the big unknown that will drive a lot of decisions on whether to participate or not. So ideally, folks would get the information as soon as possible. I know just from having been at CMI, it takes a lot to work through these details and sort of make sure you can have a model that can still achieve savings. So it's I'm sure they're working very hard on it, but I would expect that would be coming out soon, significantly ahead of the application deadline, so people can make meaningful decisions.
Mm-hmm. Okay, we have just 2 more slides on access before we turn to lead, and then to Ryan to talk to us about the broader environment. I know there's a lot of text on this slide, and a lot of these implications we've touched on already, but I've been seeing in the chat questions related to overlap or implications for broader participation. So we want to make sure we spend some time there. But first, to just touch on implications for the access participants themselves. Really, this model is looking to promote a new type of performance-based competition, where in the current environment, we have a lot of technology vendors, digital health vendors that have solutions targeting these conditions and others. But in the current environment, health systems, ACOs, MA plans, MCOs that have significant size and geographic concentration, they can select a single digital health vendor for a given condition and create this kind of winner-take-all dynamic. Also, a lot of ACOs and health plans struggle to contract with digital health solutions in a way that rewards outcomes. It's challenging to parse out or attribute savings, particularly when beneficiaries have multiple comorbidities. And then lastly, the variation that exists in the market today and how digital health vendors and risk-bearing entities like ACOs or plans negotiate these contracts. There's just so much heterogeneity that it makes it difficult to compare vendors or really to promote competition in any kind of consistent way. And so really that's what Access is looking to do, is to create a new opportunity for these tech companies to compete for Medicare lives based on their ability to achieve and to engage beneficiaries, importantly, throughout that 12-month performance period, but also achieve those measures. And it's not just enough to have a peer-reviewed paper to say that you will not receive the full payment unless you do. And so, as Amy described at the top of this webinar, CMS, their priorities for the Innovation Center on model savings, CMS is making a bet that not all access participants will be able to achieve these targets. Access participants need to make the bet. Yes, we think we can, on the whole, do this well because of our experience in the market. And for that reason, we expect in the early cohorts, at least, established players will likely be those that are among the most common participants in the model. For ACOs, I know this is a big question, at least that I've been receiving. ACOs should expect to be desirable referral partners from access participants. Access participants aren't required to have contracts with ACOs, and beneficiaries can directly sign up using that directory. That's expected to be the primary vehicle. But because of the requirements around coordinating care and that spend adjustment where you want to keep most of your beneficiaries from receiving duplicative services, it will be in the access participants' best interest to have a coordinated and close relationship with providers. Even better if it's ACO providers that are also thinking about how do we best manage this patient's care needs and keep them out of the hospital, keep them healthy. There will be an initial grace period, CMS has said, until PY28 before the OAPs, those outcomes-oriented payments, impact benchmarks and expenditures. The co-management payments, which we haven't talked a lot about, those will immediately impact expenditures, but are not expected to be very sizable. So in the short term, access could help to lift ACO performance, assuming that whatever downstream utilization that these access participants help to cause, the good kind of utilization that patients have when they're engaging actively in their care, would be offset by downstream spending that can be avoided within a performance year. So a lot of questions there on what this will actually look like. I want to touch on, and I know Amy Ryan talked about this, I think there's lots of questions in the chat. The last bullet for ACOs here, CMS has said in terms of overlap, at the beneficiary level, beneficiaries can concurrently be served by an access participant and can be aligned to an ACO. So no issues with beneficiary overlap in being served by both models. The participant overlap issue is one that's still kind of questionable. So access technically allows for participant overlap. You could be an access participant and you can be in a CMMI ACO model or the MSSP. The RFA clearly says that. But participants are not expected to align the same beneficiaries in those models. And essentially, it's this fee-for-service exclusion policy that makes it untenable for a health system or an ACO to be an access participant, even if it's technically allowed. And this is because access participants and affiliated entities cannot bill Medicare fee-for-service for any services, whether they're related to the access conditions or not, for the same beneficiaries that are being served under access. And so for that reason, we expect access to primarily be designed for tech companies rather than traditional providers that are providing fee-for-service, regular fee-for-service services to Medicare beneficiaries. Ryan, Amy, anything you'd add on this point around the fee-for-service exclusion policy or target participants?
No, I mean, I think that's right. I think there's a lot of questions in the chat about that really of like what the implication will be for that, and really if people should be thinking about whether they should apply or not. And Kate, I'm just wondering, I know looking at the time, I'm wondering if we should just go to the next slide, and not that we don't care about the beneficiaries, but the folks are interested about making those decisions. And I think so. We've listed out here a couple of questions for consideration for your application. Sort of many of these topics we've touched on already. But, do you want to apply now or do you want to apply later? This is a rolling basis. This is a 10-year model. Do you want to wait and see a little bit if it's how it's going to shake out, better information about the financing? Are there new clinical conditions that may come on that may be more attractive to you? Are you enrolled already as a Part B provider? This is the key issue of, if you haven't done that yet and you want to apply, make sure you're talking to the local MAC or MACs where you're located to go through that Part B provider supplier experience to be able to be eligible to bill Part B physician fee schedule services. Program integrity screening, program integrity, as folks know, is a very important part of this administration's priorities across Medicare and Medicaid. And so the applicant is going to be screened, but also the parent organization. So thinking about, what that may look like. Are you going to meet all the compliance requirements? And is the parent company also in good standing? CMS takes this very seriously. They work with partners across the federal government to ensure that they are going to be having upstanding and partners who don't have problems with Medicare in the past. Ryan has talked about this, sort of the infrastructure for data exchange and care coordination. Are you ready to be able to do that come July if you're applying now? We talked a lot about the outcome of the line payments. So can you address that? Are you financially in a position to wait for those later payments? Clinical track selection and sort of, do you have the evidence to support that you can do this? Your intervention is actually going to be clinically appropriate and, evidence-based that CMS would select you. And then the beneficiary overlap, the model overlap that we were just talking about really needs some further consideration. If you already are a provider, if you're in a model, in an MSSP, something else, what are the implications for that? Going quickly, I think the lead, we're going to put these slides out. Just know that there's another model, leads coming, sort of the successor to ACO REACH, that again, another 10-year model, total cost of care, risk-based model. I imagine as we will be talking more about this in other scenarios. But with that, I think, Ryan, I'll turn it over to you to go through your part of the conversation, and we will keep trying to answer questions in the chat and then have a few minutes at the end for some additional questions.
Go to the next slide. Next slide after that. All right, we're going to talk about how this all relates. And as Kate mentioned at the end, I think it's really important to identify that this is primarily a tech-first initiative. We anticipate that the majority of participants that will be applying for access will be tech-enabled companies or tech-forward companies that specifically can bill Medicare directly. And the other interesting part, as was mentioned previously, is the beneficiaries can enroll directly themselves and select an access provider themselves from essentially the app store that CMS is going to, and CMMI are going to build that's going to list all of these. Now, how does this all relate to what was announced last summer, the CMS Health Tech Ecosystem? Well, if you didn't hear about it, there was a press release that 60 organizations committed to CMS that they want to build this health tech ecosystem. It was also called Kill the Clipboard. It was also called tech-enabled services. This is an opportunity for these 60 companies to participate. There are more than 600 now that have actually participated in this, and all of the work is happening in a Slack channel. And so you can participate in this work. We'll go to the next slide. Simply by finding opportunities where you can get engaged there in the bottom right-hand corner in this tech-enabled ecosystem, where these organizations are coming together to develop standards for how FHIR-based connectivity, FHIR API-based connectivity should work. It's not a mandate, it's just a movement. It's really a collaborative effort for how this API infrastructure should be built. Many of the things that were alluded to or referenced in the access model actually relate to this CMS announcement around what a health tech ecosystem actually looks like. And so joining this is actually easier than even access, sort of a lot easier than access, in the sense that you just need to fill out a form saying that you'd like to participate, indicate which areas are of interest to you, and you can participate in this enablement of the future of really healthcare data exchange and technology. These are the work groups that are actually participating in the health tech ecosystem right now. We don't have time to go through them, but just know that there was a press release over the summer and you haven't heard anything about that since then. But there has been a ton of work happening in this Slack instance that folks are participating in, and pilots are happening, and code is being developed, and launches of this initiative is actually happening. It's just not happening in a public way in terms of press releases, but there's a lot of work happening. We'd love to have others participate as well. So many have asked, like, how does the patient actually find information or access to this information themselves? How do they aggregate kind of their own healthcare or information associated with that? Well, that folks may have heard about the OpenAI and BeWell announcement that once happened. I guess the animation got stalled there a little bit, but this is an opportunity where actually patients can actually get access to their health information from various sources today. It's a chat-based user experience. There's at least 50 organizations that are participating in this in some way, shape, or form. They've connected to these APIs in production. It allows for access to work because the patients can now aggregate their healthcare information using a series of technologies that have been built over the course of the last 10 plus years. These organizations, they've connected to these APIs in production. The security and consent is actually better than HIPAA. And we could go into more detail if we had more time around why that's the case. None of the data actually informs the LLM. It's like HIPAA plus in terms of privacy, security, and consent, and it provides these AI-powered insights. That and those initiatives and what's happening in the marketplace today with the fact that consumers can get access to this information allows for access to happen, because now individuals can be able to select one of these access tools and combined with their own health information, be able to use that tool in a way that allows for a massive amount of coverage that we haven't had before, especially for those who don't have PCPs or in rural or underserved areas or any of the other things that have been challenging. We have now an opportunity for those that, like I said, smartphone penetration now is about 95% in the country across all socioeconomic types, for them to be able to have that same experience where they can be able to have access to care where, when, and how they want to achieve their goals. What has ASTP or ONC had done in this process, and how are they actually building this health tech ecosystem? Well, there's two things that Tom Keene, who's the national coordinator, said recently last year. One of the things is they said they want to start to certify the APIs to improve interoperability. And the second thing is they want to enforce information blocking. Those two things are important because now EHRs are not going to be certified based on the actual functionality that's inside the EHR, but more about whether or not the data is exchanged in a common way, and using these more API-based aspects and functionality and technology associated with that. So what that means is that and it looks like in the commentary of the HTI-5 rule that came out in December, that they're going to increase automation API performance and move beyond read-only interactions. What that means is that this capability in Access is going that both ASTP, ONC, and CMS are certainly on the same page with how they see this new ecosystem happening. Folks will have an app of their choice. Folks will be able to send data back and forth between their physician and their app of their choice using these APIs. Performance is going to be a big topic, it sounds like, it potentially in a new rule from ONC. And they're going to move beyond these read-only interactions to read-write capabilities, meaning I can both receive and send this information to my doctor. So the years of just data being in an EHR and only being exchanged between EHRs is changing dramatically. It's number one, it's being improved with the implementation of these APIs, and number two, it's enablement of the patient actually being in the center of their care. So this is a more of an architectural picture in terms of like how we think this is going to come together, and how Access participants need to think about what type of a technology architecture they need to have in order to participate in this program. Certainly the legacy data that's here in the EHRs and the claims systems themselves will still be there. We do believe that most, if not all, entities that participate in any of these programs going forward, especially data exchange across the board, is going to have some type of a cloud-based infrastructure that actually supports the maintenance of these FHIR APIs into their own infrastructure. They'll have these API endpoints. They call them what's called G10 servers, where these FHIR API gateways will enable the ability for individuals to gain access to this data. They'll have a developer portal, a test sandbox. These are all new things, but there'll be things that are going to be empowered by this movement towards these FHIR APIs. We'll have digital identity so that we know someone is who they say they are. We know what organization or individual they represent, and we know what data they're authorized to receive. We'll have conformance tools there on the right for what happens, and then we'll know where the data is, what's called record location services across the board. We're going to have this app stores. What's really important is not only CMS aligned network apps, but also access model participants will be listed in an app store, as was mentioned earlier. And then doctors and patients can be able to go to this app store and see clinically risk adjusted data to say whether or not this app actually does what it says it's going to do. That is revolutionary. And that is going to be the foundation for eliminating all of the emails that probably you as physicians are getting all the time of like, my widget is the best widget you've ever seen in the world. Like, no, is it in that app store? Is it actually, do you show clinically validated evidence that the results that you are receiving are actually in line with what you are promising? And so that to me is going to be the barrier to entry for many of these organizations, because they don't have that clinically validated sample set, and they haven't been able to prove that they get clinically validated results either. So we'll see how that transpires, but I think that's going to be a big topic in the future. I also think it's going to be a big opportunity for commercial health plans in the future as well, to be able to link to that and be able to say, hey, these apps that now have shown these clinically risk-adjusted results, this now enables us to be able to put them on our formulary that allows us to be able to reimburse them in a similar fashion that CMS is reimbursing them too. So the whole concept of digital therapeutics, which has been kind of a dream in the past, I think now becomes a real reality with this new access model. And I think the final slide here is really, what do all data holders need over the next 3 years? Not just to participate in access, this is absolutely true for access, but really to participate in any data exchange anywhere in the country. We could go into the CMS 0057 rule or any of the other things that are coming out. Every single data holder, payer, provider, HIE, state, CBO, will need these core elements to be able to transact in this new world. One, certainly if you're a physician, and again, this is obviously just for clinicians themselves, but they'll need some type of clinical workflow or billing software. Mainly that right now is obviously for clinicians that bill Medicare or Medicaid, but there are other public health sometimes have some of those EHR components to it as well, but they need that core legacy system. Second thing is they're going to need some type of what we call a G10 API FHIR server, which means G10 is actually the regulation that's pointed to in ONC for these APIs that are now going to be required. But they're going to need some kind of an API FHIR server to actually say, like, this is how you connect to us. This is the developer portal and test sandbox. Here's how you reach us. They need the ability to send and receive those FHIR APIs. Inferno is an open source tool that actually allows that to happen. They're going to hopefully get it certified by Inferno as well, because Inferno can say, hey, did you do what we said you're going to do? And is this data being sent in the manner that's consistent with the regulations? We don't have time to talk about the picky framework, but what we've realized is as the data is leaving the systems, they're kind of ugly and gory, and it's not really well structured in any way. Picky framework is an open standard that actually helps normalize that data. They're going to need to know identity too, both individual and organizational identity. Are you who you say you are, and what data you're authorized to receive? We see the advent of open data models too. Graphite Health is one example of that, where in that cloud-based data store, you can have an open data model that you can store this information in. And we think that cloud-based architecture is going to become table stakes for how you actually work. So as you're thinking about the future architecture of your own system, especially if you're data holders, make sure you consider these things as you make those decisions. Kate, back to you.
Thanks, Ryan. We've got a lot of questions in the chat and interest in that Slack channel information you mentioned. And then another question, could you say more about the CMS App Store, Ryan? We have a question, will it be a requirement to have an app or platform for a patient to access via the App Store?
So the App Store is going to have two things in it. One, it's going to have applications that consumers can use to access their own health information. That's part of the health tech ecosystem. We anticipate there's going to be some kind of certification process for those apps as well. And then the other app store is obviously CMMI and the access participants themselves. We don't know if it's going to be the same app store or two different app stores. I'm assuming it's CMS. It's probably going to be the same. Maybe it's going to be different. Amy knows CMS is a big place. Hopefully, I'm sure they'll talk to each other. But the idea is that they will have an opportunity to, beneficiaries will, to be able to select some of those. Blue button is the claims information that's being sent today from CMS. There's a list of blue button apps already on the CMS website as well to do that. On the Slack channel, I'll type that answer in there to do it. You can just go, you can Google actually Health Tech Ecosystem CMS, go to their website and be able to fill out the form, but I'll put that as part of the answer here.
Okay, great. There are a lot more questions than we'll be able to get to over the next 4 minutes, but a couple of these we may be able to just quickly knock out verbally. Someone asked, is CMS interested or encouraging states to engage in the model on the Medicaid side via ILOS? And the answer is yes, in that CMS has said in the RFA and the access details to date that while this model is only for traditional Medicare beneficiaries, they want to encourage other payers, including MA plans and states, to align with access. And they'll do that through a few ways. In addition to this directory that Ryan's been mentioning, they also are going to release a series of payer-focused materials, contracting templates, implementation guidelines. And the idea is, instead of the natural, organic thing that tends to happen with CMMI models, where the market tends to follow where they're headed, CMS will more intentionally facilitate that alignment through a series of materials, and they specifically call out states and using that in lieu of services option as a way to align. So that's a great question. We have a lot of questions in the chat around the who is the target participant and what are the implications for traditional providers and ACOs. CMS has left open the door for traditional providers and ACOs to concurrently participate in access and, reach. I know that's ending, but potentially lead or MSSP. But because of the fee-for-service exclusion, that you can't be an access participant and either directly or indirectly through affiliated entities bill Medicare fee-for-service for other services given to the same beneficiary during the access care period. So if you have to decide, do I want access outcomes or aligned payments? Do I want those OAP payments for my tech-enabled care solution, or is my fee-for-service revenue for the Medicare population greater than the potential upside of the OAPs because of that fee-for-service exclusion? So we'll also take offline the remaining questions that we received in the chat and look to address those asynchronously. The slides and recording will be circulated and made available on the website. We're grateful for your time today. Our last couple of slides just telling you a bit more about HMA and our value-based care advisory services team, of which the three of us are a part, and a much broader bench of experts here at HMA. But really across the firm, we serve a full spectrum of organizations that are either interested in participating or actively participating directly or otherwise impacted by these models. So the entities that are looking to engage both with Medicare and CMMI and with other payers, entities that partner with or served by participants, and otherwise those that are just interested in studying and advancing this movement. This is a bit of a menu of some of the services that we provide for organizations in understanding the marketplace, what model options exist, how those models are impacting their geographic markets or their segments, how to effectively evaluate partners and engage stakeholders, and really, as it relates to access, how to assess your readiness and what are the most favorable model options for you with which configuration of participants or which populations. So really, it's that readiness assessment is where we recommend you start, and then can support applications themselves and implementation when the time comes. And then, of course, optimizing performance. They're not represented here, but our colleagues at Wakely are actuaries that support many risk-bearing entities and also provide that kind of financial modeling angle. We're all very eager to see the final payment details, and when that time comes, I'm sure our colleagues at Wakely will be very busy. Amy, Ryan, thank you so much for your time today. Thanks everyone for joining us. Until the next time.